Perfect. I see people are logging in. And as people are logging in, I will start with my basic information. So I'm Gabrielle Altit. I'm a neonatologist based in Montreal at the Montreal Children's Hospital. And it's really a pleasure and honor to be able to co-chair the sessions of the TNE NPE Foundation curriculum of the Neonatal Hemodynamics Research Center alongside my colleague, Dr. Amy Stanford, who's based at Iowa. I would like to start by thanking Ms. Laura Thomas and Ms. Megan Hudak for all their support and help in coordinating these sessions, which have been quite instrumental in supporting the learning of our community. And so I'll start by saying that we do have credits from the Royal College of Physicians and Surgeons of Canada of the Section 1 if you want to claim CMEs. We did have in the past other sessions related to acute pulmonary hypertension, which were presented by Dr. Marjorie Makoni and Dr. Rachel Hyland. And so we invite you to visit the YouTube channel of Neonatal Hemodynamics Research Center in order to explore the content of these sessions that are in link with the topic of today. But there is a wealth of sessions there that you can access for self-directed learning. We do want to remind you that there is the Dr. Regan Gissinger Clinical Cardiopulmonary Physiology for the Care of the Sick Newborn course, which will take place online November 2nd to November 6th, 2026. And registration is open, and we will put the link in the chat. It is really a fantastic course that has extraordinary speakers. So we really, really encourage you to register for these sessions that will take place over the course of a few days. And I do want to remind everyone to please send us your feedback. We will be putting a link in the chat. And so this allows us to continuously improve the content of these sessions. Now, for today, we are very privileged to have Dr. Pearl Shatmitakul from Iowa. So she's a clinical assistant professor in the Division of Neonatology at the University of Iowa Healthcare Stead Family Children's Hospital. Her work focuses on applying expertise in neonatal hemodynamics and targeted neonatal echo to guide management. And she's also committed to expanding access to specialized neonatal hemodynamic services in regions where such expertise is limited. She will be joined by two panelists for the moderation of the Q&A session. So we'll have today Dr. Srirupa Harigopal, who's an assistant professor in neonatal perinatal medicine at St. Louis University Cardinal Glennon Children's Hospital with interest in neonatal hemodynamics, specifically in the pulmonary hypertension of congenital diaphragmatic hernia and in neonates with hypoxic ischemic encephalopathy, as well as Dr. Irina Prelipshin, who's a staff neonatologist in pediatrics neonatology of Florida at Winnie Palmer Hospital for Women and Babies. Her area of academic focus is improvement of outcomes in critically ill neonates, specifically on the hemodynamics and biomarkers involved in neonatal adrenal and brain dysfunction. So today's TNE talk will be on acute pulmonary hypertension and right ventricular dysfunction. Dr. Pearl will be presenting, and then we'll have our Q&A session. So please make sure to put your questions in the chat so that we're able to drive the discussion. And on this note, I will let Dr. Shatmitakul take over for her lecture. Thank you so much. Oh, Pearl, you're still muted.
Oh, here. Can you guys see my slide now too?
Yes, both.
Okay.
We hear you and see. Thank you.
All right. Thank you. Thank you so much for your kind introduction. And thank you so much for having me here today, sharing with you guys on the topic of pulmonary hypertension. So As a component of many neonatal disease processes, pulmonary hypertension can be differentiated into acute and chronic forms. Both presentations differ in their time of onset, etiology, and associated conditions. For this talk today, I will only focus on acute pulmonary hypertension in infant with structurally normal heart. So over the next 30 to 40 minutes or so, I'm planning to go over these three objectives: phenotypic presentations of acute pulmonary hypertension, how can we approach acute pulmonary hypertension physiologically, and end with clinical implementation of targeted neonatal echocardiography and neonatal hemodynamics through a case discussion. So to understand pulmonary hypertension, let's talk about what normal transition is first. In the fetus, the ductus arteriosus is an important vascular connection that diverts blood from the pulmonary artery into the aorta bypassing the lungs. During fetal life, the pulmonary vasculature is constricted, resulting in a high vascular resistance within the pulmonary bed. In contrast, the placenta creates a low resistance circuit arising from the aorta, and systemic vascular resistance is low. So as a result, the majority of blood exiting from the right ventricle passes right to left across the ductus arteriosus into the descending aorta, supplying the systemic circulation of the fetus and onto the placenta for gas exchange. During canalicular stage of lung development, PVR is high because of paucity of the pulmonary vascular network and a reduced cross-sectional area of the immature pulmonary vascular bed. Later in alveolar stage, during late preterm or early term gestation, there is a marked increase in the cross-sectional area of the pulmonary vascular bed. However, during this phase, the pulmonary vessels become more sensitive to vasoconstrictive mediators, such as relative hypoxemia, which then induces active pulmonary vasoconstriction and result in high PVR. For a newborn to successfully transition from intrauterine to extrauterine life, a series of physiological events must occur to support independent extrauterine life. With the onset of respiration after delivery, the lungs expand and the systemic oxygen saturation rises. This results in pulmonary vascular vasodilation and a drop in pulmonary vascular resistance. At the same time, systemic resistance rises with placental removal. These factors lead to a reversal of blood flow in the ductus arteriosus from right to left to right shunting, with concomitant increase in left ventricular output. Typically, when we are talking about acute pulmonary hypertension, we usually refer to the resistance-mediated phenotype, which manifests shortly after birth and is secondary to impaired or delayed relaxation of the pulmonary vasculature. And it represents a syndrome of impaired circulatory adaptation. However, the pathogenesis of PH is multifactorial, with numerous risk factors that could lead to disruption of the normal transition from fetal to postnatal circulation. Therefore, pathophysiology of PH is complex, involving respiratory, circulatory, and metabolic derangements, all of which can contribute to impaired oxygenation and cardiovascular instability. As an example of how complex and acute pulmonary hypertension can be and how we can utilize neonatal hemodynamics and targeted neonatal echocardiography to provide a physiologic-based management, I would like to bring your attention to a case. This is a case of a 29-week girl with history of prolonged premature rupture of membrane 13 days prior to delivery. There was anhydramnios, secondary to lower urinary tract obstruction, and fetal hydrops. He was born by C-section due to placental abruption with the Apgars of 1 and 5. Despite pulmonary intervention and significant ventilatory support, he remains with significant hypoxemia, hypercapnia, with a chest X-ray that is consistent with pulmonary hypoplasia. Cardiovascular-wise, he was normotensive, but with prolonged capillary refill time and had a weak pulses and lactic acidosis. With this presentation, most of us would think of acute pulmonary hypertension, but how certain can we be, and what management strategies should we implement? Usually in critically ill neonates who presented with hypoxemic respiratory failure or severe hypoxemia, the term neonatal pulmonary hypertension is typically mentioned and widely used. However, neonatal PH involves a complex interaction like I have discussed before, which is quite unique, as well as other illnesses affecting the newborn, especially underlying infections and or perinatal hypoxic ischemic events. As you can see in this patient, he had a lot of perinatal conditions that could contribute to his severe hypoxemia and poor tissue perfusion. Therefore, managing him without further insights into underlying physiology could be challenging. This is when a thoughtful understanding of real-time pathophysiology is critical for providing optimal care to affected infants. This brings us to the fact that although elevated pulmonary arterial pressure is frequently considered to be primarily a resistance-driven disorder due to increased PVR, excessive pulmonary blood flow and increased left atrial pressure in the setting of left ventricular dysfunction are also important causes of neonatal pulmonary hypertension. The ability to delineate phenotypic features of the acute pulmonary hypertension allows for appropriate institution of cardiopulmonary management, especially in the utilization of pulmonary vasodilator. A comprehensive understanding of the interplay between PVR and pulmonary blood flow is fundamental to fully grasp the pathophysiology of PH. This relationship is governed by Darcy's law, which states that flow is equal to pressure gradient divided by resistance. In physiologic terms, this can be expressed as the following equation, in which mean pulmonary arterial pressure and is the relationship between pulmonary blood flow, pulmonary vascular resistance, and PCWP, which is pulmonary capillary wedge pressure, is approximates of left atrial pressure. Clinically, this principle helps to distinguish between elevation in pulmonary arterial pressure that are driven by increased flow versus those resulting from elevated PVR or elevated LA pressure. Each phenotype is defined by distinct hemodynamic alterations, clinical presentations, and echocardiographic findings. So let's start with the concept of pre-capillary pulmonary hypertension, which is fundamentally a resistant-mediated problem. In this phenotype, the pulmonary vascular resistance remains elevated, creating a major obstacle to blood flow leaving the right ventricles. The right ventricle is pushing against a high resistant circuit, leading to an increased right ventricular afterload, and in severe cases, impair right ventricular systolic function. When blood cannot easily flow through the pulmonary circulation, the pulmonary venous return to the left atrium decreases. As a result, left ventricular filling may be compromised, reducing systemic output and contributing to cardiovascular instability. As you can also see here, the in the picture with the patent ductus arteriosus, because the pulmonary arterial pressure remains high, the PDA may initially shunt blood from the pulmonary artery towards the aorta, creating a right to left or bidirectional shunt pattern. Now let's move from pre-capillary phenotype to post-capillary pulmonary hypertension. Unlike pre-capillary disease, where the problem starts in the pulmonary vasculature, here in this phenotype, the pathology begins on the left side of the heart due to poor left ventricular compliance or poor left ventricular function. A stiff ventricle, even if it contracts normally, cannot relax adequately to accept blood during diastole. Similarly, a weak ventricle may not generate enough forward flow during systole. Both of these situations result in elevated filling pressures within the left ventricle. As shown in this diagram, this leads to an increase in left ventricular and diastolic pressure and left atrial pressure. Now, blood returning from the lungs has nowhere to go efficiently. The elevated pressures in the left atrium are transmitted backward into the pulmonary veins and subsequently into the pulmonary capillary bed. This is why we call it post-capillary pulmonary hypertension. The elevated pressure originates downstream of the pulmonary capillaries and back up into the pulmonary circulation. As pulmonary venous and capillary pressures rise, the lungs become congested, impairing gas exchange and increasing respiratory needs. Last one is the flow-mediated or flow-driven phenotype, which is characterized by elevated pulmonary arterial pressure secondary to increased pulmonary blood flow. I am using the example of vein of Galen malformation as the prototype lesion here. In this phenotype, the fundamental problem begins with a large preductal AV malformation in the brain. This creates a low-resistant pathway that continuously steals blood from the systemic circulation. As a result, an unusually large volume of blood is shunted to the malformation and returns through the venous system. Massive venous return through SVC caused dilation of the SVC and right atrium, leading to a volume-loaded right ventricle with increased right ventricular output. That increased right ventricular output is delivered to the pulmonary circulation, producing excessive pulmonary blood flow, and subsequently marked pulmonary venous return to the left side of the heart. The left ventricle then becomes dilated and hyperdynamic because it must pump not only to the normal systemic output, but also to the recirculated blood volume generated by the AV malformation. In other words, this is a state of high output cardiac failure. Therefore, with the different phenotypes and with different hemodynamics concerning each phenotypes, a detailed and multi-parametric echocardiographic assessment, including evaluation of shunt magnitude, chamber size and function, septal position, pulmonary vein flow, and TR jet velocity is essential for an accurate phenotyping and to help guide optimal therapeutic intervention. Moreover, targeted neonatal echocardiography enables real-time assessment of physiologic changes over time, as well as monitoring therapeutic response. Now let's go over each of the assessment component on T&E. One of the most important components is the estimation of pulmonary arterial pressure. In echocardiography, we rely on a few key surrogate measures rather than direct pressure measurements. Two most commonly used are the tricuspid regurgitation jet velocity, or TR jet, and the left ventricular systolic eccentricity index. The tricuspid regurgitation jet, when present, and of adequate quality provide the most direct non-invasive estimate of right ventricular systolic pressure. Systolic pulmonary arterial pressure can be estimated by measuring the peak velocity of tricuspid valve regurgitation with the use of modified Bernoulli's equation. Right atrial pressure is not usually measured, and a value of 3 to 5 millimeter mercury is generally assumed. The estimation of systolic pulmonary arterial pressure by measuring TR-jet is reliable and often equivalent to pressures measured in the cath lab. However, the accuracy of the TR-jet really depends on the quality of the TR-jet acquired. Measuring an inadequate Doppler spectral envelope will potentially lead to an underestimated pulmonary pressure. Moreover, this estimation of pulmonary pressure is not reliable in the presence of right ventricular failure or right ventricular outflow tract obstruction. And lastly, TR-jet cannot always be observed and only present in approximately 60 to 85% of patients with pulmonary hypertension. The second parameter is the left ventricular systolic eccentricity index. This is an objective measurement of interventricular septal configuration obtaining from parasternal short axis view. Normally, the left ventricle appears circular during systole. As right ventricular pressure rises, the interventricular septum flattens and may even bow towards the left ventricle, causing the left ventricle to become more D-shaped. The eccentricity index allows us to quantify this septal flattening rather than simply describing it qualitatively. As pulmonary arterial pressure increases and approaches systemic level, the septum becomes progressively flatter and the eccentricity index rises. An important advantage of eccentricity index is that it is often obtainable even when a TR-jet is absent. It is therefore being able to provide a valuable complementary assessment of pressure loading in the right ventricles. Next is the assessment of pulmonary vascular resistance through pulmonary artery Doppler interrogation. To obtain this image, we start with parasternal short axis view, where we can visualize the main pulmonary artery and position the pulse wave Doppler just distal to the pulmonary valve. The Doppler waveform generated from blood flow through the pulmonary artery contains information about the pulmonary vascular bed downstream. In a normal circulation with low pulmonary vascular resistance, blood accelerated quickly and continued forward throughout systole, producing a smooth isosceles triangle Doppler envelope. As pulmonary vascular resistance rises, the right ventricle encounters greater opposition to flow. This alters the shape of pulmonary artery Doppler waveform. Specifically, we begin to see a shortening of the pulmonary artery acceleration time, often accompanied by a more peak waveform, and in severe cases, mid-systolic notching. Physiologically, this occurs because reflected pressure waveform from the pulmonary vascular bed return earlier when resistance is elevated. The right ventricle therefore faces a higher afterload earlier in systole, changing the flow profile that we record with the Doppler. One of the strengths of pulmonary artery Doppler assessment is that it provides information about resistance rather than pressure alone. Now that we have discussed pulmonary artery pressure and pulmonary vascular resistance, let's talk about a third critical component of pulmonary hypertension assessment, which is ventricular performance. When we estimate pulmonary artery pressure using echocardiography, we are essentially measuring the pressure that the right ventricle is able to generate against the pulmonary circulation. But that pressure measurement doesn't depend solely on the pulmonary vascular resistance. It also depends on the ability of the ventricle to generate flow. The pressure estimates are only as good as the ventricle producing them. Therefore, weak ventricles may generate deceptively low pressures, causing severe pulmonary vascular disease to look less severe than it truly is. For left ventricular function, multiple modalities are used for assessment, including ejection fraction, tissue Doppler imaging, and M-mode-derived fraction shortening. Similarly, for right ventricle, we typically assess tricuspid annular plane systolic excursion, fractional area change, as well as tissue Doppler imaging. Assessing ventricular performance in pulmonary hypertension goes beyond simply measuring contractility. We also need to understand how right and left ventricle influence one another. This concept is known as ventricular-ventricular interaction. In the normal heart, the septum maintains a balanced position between the two ventricles, allowing both chambers to fill and contract efficiently. However, when pulmonary vascular resistance rises and right ventricular pressure increases, the right ventricles begin to dilate and push the septum towards the left ventricles. As illustrated at the bottom of the slide, the left ventricles change from its normal circular shape into a more compressed configuration. This septal shift reduces left ventricular filling and can decrease systemic output, even when left ventricular contractility itself is normal. So a child with very severe pulmonary hypertension may develop systemic hypoperfusion, not because the left ventricle is intrinsically weak, but because the pressure-loaded right ventricle is physically impairing the left ventricular performance. The second concept is ventricular interdependence. The images at the center of the slide highlight the complex myocardial fiber architectures of the heart. The right and the left ventricles are not composed of completely separate muscle units. Instead, they share contractile fibers that wrap across both ventricles in a continuous three-dimensional network. Ultimately, ventricular performance reflects not only myocardial contractility, but also the dynamic interplay between the two ventricles. Understanding these interactions helps explain why some infants with pulmonary hypertension develop profound systemic compromise despite having relatively preserved left ventricular systolic function. Next is the assessment of transductal flow. A ductal right to left or bidirectional shunt is observed in most of the patients with pulmonary hypertension. An assessment of the direction of transductal blood flow is more useful and will indicate the relationship between pulmonary and systemic pressure. Last but not least, another useful assessment is the atrial level shunt directionality. Normally, the left atrial pressure exceeds right atrial pressure after birth, resulting in either left to right flow or functionally closure of the foramen ovale. When we see the right to left shunting across the atrial septum, it is a marker that raises concern that the right-sided pressure may be elevated. But remember, the shunt direction is determined by both pressure and compliance. Atrial level shunts are a clue to the physiology, not a standalone measurement of pulmonary hypertension. Over the last several slides, we have discussed how to assess pulmonary artery pressure and pulmonary vascular resistance, shunt direction, and ventricular performance. The next step is to putting all of those findings together into a physiology-based phenotype. The key principle is that not all pulmonary hypertension is the same. Across all phenotypes, the common feature is elevated mean pulmonary arterial pressure. However, echocardiographically, those phenotypes differ. In all of the phenotypes, we may see elevated right ventricular systolic pressure estimated by the TR-JET, septal flattening, abnormal septal motion, or bidirectional and right to left ductal shunting. However, these findings only tell us that pulmonary hypertension is present, not why it is present. The first phenotype, which is pre-capillary phenotype, here the dominant problem is an increase in pulmonary vascular resistance. Echocardiographically, we often see right to left atrial shunting, reduced pulmonary blood flow, right ventricular dilation or dysfunction, and elevated indices of pulmonary vascular resistance. Because the primary problem is pulmonary vasoconstriction, these infants typically respond well to inhaled nitric oxide and other selective pulmonary vasodilators, which reduce right ventricular afterload and improve oxygenation. In post-capillary phenotype, the primary problem is in the left side of the heart. Therefore, the echo may demonstrate left to right atrial shunting, enlargement of the left atrium and the left ventricle, and the evidence of left ventricular dysfunction. Importantly, pulmonary vasodilator may be problematic in this phenotype. If we lower pulmonary vascular resistance and increase pulmonary blood flow into an already congested pulmonary venous system, pulmonary edema and hypoxemia may worsen. In flow-driven pulmonary hypertension, the pulmonary pressure are elevated not because of resistance is high, but because pulmonary blood flow is excessive. These infants often have high cardiac output state with evidence of volume overload, including chamber dilation, increased pulmonary venous return, and a hyperdynamic left ventricles. Because the primary issue is excessive blood flow, pulmonary vasodilator may actually be harmful. By further lowering pulmonary vascular resistance, they can increase left to right shunting, worsening pulmonary oversaturation, and compromise systemic perfusion. This framework highlights how phenotypes matter. The goal of targeted neonatal echocardiography is therefore to move beyond a diagnosis of pulmonary hypertension and ask a more important question. What is the driving force or driving course of the pulmonary hypertension in this patient? Once we identify the dominant phenotype, we can then tailor therapy to the underlying physiology rather than treating all pulmonary hypertension as a single disease. Now, after we have gone through all the phenotype and all the assessment, let us revisit back to the case I told you about in the beginning, a preterm infant with hypoxemic respiratory failure and lactic acidosis. In this patient, secondary to his severe clinical status, an emergent scan protocol was utilized to initially identify the above goals, and as soon as the patient clinical status has improved, a full T&E was then completed. What we found was that the baby has suprasystemic pulmonary hypertension in the presence of a large exclusively right to left PDA and moderate LV dysfunction with secondary mild RV dysfunction. The baby also had decreased left ventricular output with moderate mitral valve regurgitation. Atrial level shunt is exclusively left to right, indicative of a post-capillary phenotype as the etiology of current presentation. As previously described, This in infant with post-capillary pH phenotype, poor LV function leads to inefficient ejection of end-diastolic volume, resulting in a progressive increase in left ventricular end-diastolic pressure, resulting in pulmonary venous congestion. Determining the relative contribution of LV disease is an important consideration in the rational selection of therapy. Where there is a primary LV disease, RV afterload reduction with selective pulmonary vasodilators such as inhaled nitric oxide may worsen pulmonary venous congestion and perpetuate the hypoxemia. Increases in LV afterload through aggressive vasopressor use may also be poorly tolerated in these patients. Therefore, the alternative therapeutic approach is necessary in this phenotype, including positive inotropy, avoidance of pulmonary vasodilators, and considerations of LV afterload reduction and lusitropic medication if systemic artery pressure is adequate. Following the initial assessment, inhaled nitric oxide was discontinued, and this infant was started on epinephrine infusion as well as lung optimization therapy, and correction of metabolic acidosis was being performed. Serial TNE, however, continued to show persistent suprasystemic pulmonary hypertension with moderate LV systolic dysfunction and a normal RV function consistent with persistent post-capillary phenotypes. Mirinone was then added at about 10 hours of life as a lusitropic and afterload reducing agent once the infant has shown to have adequate markers of renal function. However, at 27 hours of life, the patient again developed worsening hypoxemia and lactic acidosis, as you can see here. On his clinical trajectory, as well as his chest x-ray findings that were difficult for us to delineate the underlying pathophysiology of this severe presentation. A repeat TNE was then performed. The assessment showed again suprasystemic pulmonary hypertension in the presence of a large exclusively right to left PDA, but with normalization of biventricular systolic function and bidirectional atrial level shunt, and the markers of elevated pulmonary vascular resistance. This assessment is consistent with resistant mediated pulmonary hypertension. In resistant mediated pulmonary hypertension, there is a high pulmonary vascular resistance, which can result in a cycle of reduced pulmonary blood flow, worsening acidosis, and progressive hypoxemia, which is evident in this patient. In resistant-driven acute pulmonary hypertension, treatment include reduction of PVR using pulmonary vasodilator, augmentation of RV performance with inotropic support, as well as RV afterload reduction. Ensuring adequate RV perfusion pressure and supportive care of the underlying condition is also important. With normalization of biventricular function and at this time more phenotypic feature of resistant mediated pulmonary hypertension, our patient was then started on inhaled nitric oxide as well as stepwise increase in the dose of mirinone as clinically tolerated with serial targeted neonatal echocardiography. As you can see here, the patient subsequently has improvement in both echocardiographic markers and clinical presentations, including improvement in oxygenation, ventilation, and lactic acidosis. I hope that this patient highlights how complex and dynamic a patient with acute pulmonary hypertension can be. And while supportive therapy and maintenance of normal physiological status are very important, it is of utmost importance that we are being thoughtful of the underlying phenotypic features of pulmonary hypertension so a targeted and precise therapy can be administered. As we are coming to the conclusion of this presentation, I would like to use the last 2 slides of this presentation to summarize the echocardiographic feature and therapy for each phenotypes. However, in real life scenario, things can be more complicated and difficult to delineate. But in brief, for resistant mediated pulmonary hypertension, you could see dilated RV with predominantly right to left ductal and atrial level shunt with decreased left ventricular output. For flow mediated pulmonary hypertension, RV will be dilated with increased cardiac output that can be discordant depending on the lesions. And for post-capillary phenotype, you most likely will see a dilated left atrium with left to right atrial level shunt and decreased left ventricular output. As for targeted therapy, like we have gone through earlier in this case discussion, for resistant mediated pulmonary hypertension, the care is focused on PVR reduction and augmentation of RV performance. While for flow-mediated pulmonary hypertension, the shunt modification and maintenance of higher PVR is a cornerstone. And lastly, for post-capillary phenotype, augmentation of LV performance through positive inotropy and afterload reduction with maintenance of right to left ductal shunt for adequate systemic blood flow is the foundation of therapy. Thank you so much for your attention, and I'll be happy to take any questions.
Thank you so much for this really wonderful presentation and summary of this complex topic. We could do probably a whole symposium on it.
Yes,
so it's great.
It was a really big talk. So I was hoping that I did not take too much of the time away from the discussion.
Great. We'll have 20 minutes and we have our 2 panelists on the line as well. So I'll open, I guess, this discussion with everyone. We already have some questions in the chat. And I think one of the questions that came up is related to what are potential mimickers like congenital heart defects and the role, of course, of ruling out congenital heart defect in some of these presentations and kind of clinical pearls that you may have for the audience about trying to kind of make themselves an approach to decide what to and how to intervene. So I'll let pretty much everyone answer what their thoughts are on this question.
I think, Rupa, I think you're muted still. I think I can start too. That's why in the beginning of my presentation, I did mention that the talk will be focusing on approach to pulmonary hypertension in a newborn with structurally normal heart. And that is one of the first thing that we assess for when we are performing targeted neonatal echocardiography or when you're obtaining an echo images. Yep, we can hear you now.
Sorry about that.
No, that's okay. That's why when you have a baby that present with severe hypoxemia out of the proportion of the lung disease or not responding to pulmonary optimization, obtaining an echocardiography is important because it is one of the first things that you want to rule out, and that is congenital heart disease. And that's what we always look for as well when we are performing targeted neonatal echocardiography. If there is a congenital heart disease, the management will be very different based on the lesions that you find.
Irina, maybe, and Rupa, if you have anything to add to this particular topic.
Hoping people can hear me now. Yes?
Yep.
Okay, perfect. That's such an interesting question. Firstly, Pearl, that was a fantastic talk. Such an interesting topic. And the question about thinking about what could be the other mimickers of a right to left shunt and pretty much a presentation of hypoxemia and pulmonary hypertension mimickers. And I think you rightly said that a congenital heart disease is something that always comes to all of our minds. And I think of these presentations in a scenario of where am I located? Am I located in a place that I can grab an echocardiogram, or we have a targeted neonatal echocardiogram opportunity to do and quickly assess the baby? And the goal typically is all of the things that you rightfully said about assessment of pulmonary arterial pressures, the ductal level shunting, the atrial septal level shunting, function, all of that. But in addition to that, we also want to make sure that this is not a CHD. So the goal is also to make sure this is not what we're dealing with. And of course, physical exam findings too. If there's no risk factors for pulmonary hypertension, there's obvious risk factors or physical signs of coarctation of aorta. I think those are things to consider. And one of the most beautiful medications that we use in neonatology is PGE. I'm a big proponent of PGE. PGE has pulmonary vasodilatory properties as well. So if you're in a lower level NICU and you're not 100% certain which way this is, and you're going to have that delay in getting your echocardiogram, starting that PGE and transferring the baby is something that we all sometimes have to deal with. And that's okay. And as soon as the baby gets to a higher level of NICU, getting and grabbing that first assessment of physiology is always helpful, which can take us in the direction of which way to go for the baby. Irina, your thoughts?
Yeah, I agree. I think, it really emphasizes the fact that the shunt direction reflects the pressure, that reflects the pressure gradient between the pulmonary artery and aorta, and not just PVR alone. So thinking within, for me, it helps to think of the ductus. That's one aspect of the echo, right? That's why we use that multi-parameter approach to be able to integrate all the information that we have, and not just rely on, the PDA is right to left, right? And then that therefore there must be pulmonary hypertension. So thinking within those lines of, yes, it reflects the pressures between those two vessels, and what else can increase the pressure on either sides, right? We're talking about, whether it's left to right or right to left. So integrating that, not taking in isolation. Of course, the clinical picture is hugely important. All the clinical data that we have, and we've been trained to recognize and integrate, equally helpful, right? The echo is not the whole thing. So
yeah, 100%. I agree with you. I agree with everything that was said, and I think, as you mentioned, the trajectory of the patient, the clinical story, the physical exam, like, is there femoral pulses? Do you have pre and post ductal blood pressure gradient? Is the perfusion something concerning that you should be ruling out, obstructive lesion? And sometimes even the preductal information can be quite informative. Like if you are satting 100% preductally, then it's unlikely that you have a meaningful right to left shunting at your atrial level. So there must be something else happening. And so I think putting all the story together, the TNE, and of course, depending on the capacity of your center and the skills of the person evaluating the patient, that you have to judge the urgency of intervening right away with some therapeutics to rescue the phenotype that you presume is currently worsening the clinical situation. And of course, managing these patients in multidisciplinary fashion, especially when they're so critically ill. When you have a blue baby, you don't want to miss a TGA, you don't want to miss a TAPVR, and of course, you don't want to miss these obstructive lesion of systemic blood flow if you're going to start intervening with pulmonary vasodilators. And I think, Pearl, your case was great because you've shown that here, at some point during the trajectory of this patient, the duct was actually supporting your systemic blood flow. And so trying to disrupt this PVR to SVR relationship, you may actually worsen the clinical scenario, even in the absence of an actual structural lesion. So that's where I think the functional assessment integrated to the whole clinical story makes a big difference. I think we'll go on with the next question. There's someone who asked in the Q&A, if you had some pearls based on your reading, experience, and expertise related to some of these agents that are targeting kind of the systemic compartment. So I guess like vasopressin or epinephrine, when you're looking at potentially restoring diastolic blood pressure, and whether or not it may influence also your pulmonary vascular compartment in situations where your PVR may already be a bit high. So would love to hear your thoughts on that. And specifically, they were talking about specific agent and dosing range that you use in your practice.
So I guess it just, I will go ahead and start then, and then I will let Rupa and Irina chime in for further thoughts. In the setting of, so I think it goes back to delineation. What is the phenotype of pulmonary hypertension that we are dealing with? I think historically there is thought that we have to raise the blood pressure high in acute pulmonary hypertension, but nowadays we know that that can be contraintuitive to what we are trying to achieve. Therefore, maintaining normal blood pressure to maintain adequate coronary arterial perfusion is just adequate. And the vasopressor that we tend to use in our institution in the baby that has pulmonary hypertension is vasopressin. Since vasopressin has no side effects on increasing pulmonary vascular resistance, it does not have an effect on the heart rate. So then the baby would not be like experiencing worsening force frequency relationship. There have been a few studies that show that other vasopressors such as dopamine or norepinephrine in the setting of high FiO2, those two can augment the increase in PVR. So those two medication might not be a good one if you are handling a case with severe pulmonary hypertension, especially those that is resistant mediated phenotype.
I echo Pearl's thoughts about this. I think one of the things that for pulmonary hypertension babies that we also do at bedside quite often is sedation and heart rate management too. And that is so vital in these babies and something that's quite under-recognized, that these babies' heart rate is so essential. They don't have time for their coronaries to fill if their heart rates are that high. And so that also plays a role in your vasopressor and inotropic choices. If their heart rates are in the 180s, then, we're probably causing more harm than help in this situation. There's so much data now coming up about coronary perfusion pressure and how these babies basically have myocardial ischemia because of how high their pressures are, their RV pressures are. And so keeping in mind that we shouldn't add more problems to the situation by increasing the heart rate as much as possible and trying to keeping it at an optimal level, whether it be sedation, whether it be heart rate management. But in terms of vasopressor choices, vasopressin is a fantastic choice. Everything comes with some side effects, and keeping that in mind in the context of what's going on is helpful. If you're dealing with sort of a sepsis-induced pulmonary hypertension, RFE is not a bad choice, but then also keeping in mind that heart rate situation, those cases as well. Epi is usually a very, very quick choice. Personally, for me, giving that little extra support to the heart. But again, I always worry about the heart rate in these situations. Irina, what are your thoughts? Curious to know that.
Yeah. I think this is the whole art of hemodynamics, right? It's tough because we don't have drugs that are very clean. And I think you touched on that, Rupa, that they all have the side effects. So I think I choose where I think about the vasoactive that, kind of based on the reason that that my systemic circulation is failing. Like you said, I think you touched on that, right? If I have significant vasoplegia, then vasopressin or epi would be, if I have LV dysfunction, then which, definitely I'm going to gear more towards an epi nor epi. And then, if I have an adequate preload, but in general, that then would be a vasopressin, and preload and slowing the heart rate. So I think, it's, as long as you don't just treat the number alone and think about what, think more about what am I dealing with and what's the reason for the systemic circulation being down, and as you mentioned, I need some of that pressure to be able to perfuse the coronaries and reduce some of the right to left shunting at that point. And I wanted to, I think, touch on I don't know if units curious from other people can chime in from other units. I still remember, the whole, well, let's drive those systemic pressures all the way high and reverse that shunt. I think we still have some of that thinking in some units. It's kind of it's become a pet peeve, normal systemic blood pressures are great, but over, hypertension on the systemic side, of course, is not helpful. But I'm curious to hear if there's still that practice out there from other people in other units. I'm trying to engage.
I think it depends the situation. Let's put it that way. I think if you have, one of the things where I see that norepi and vaso or agents that will support the SVR are of particular use is when I see the diastolic systemic blood pressure like falling off very significantly. And then I start getting concerned about my kind of diastolic perfusion pressure for the coronary system. Especially like Rupa, you mentioned, if you have on top of it a situation where you have sepsis and you're concerned that there may be like vasomotor dysregulation, or you may have a situation where your patient is on some agents. Like I see one of the questions is related to dexmedetomidine, but sometimes we give fentanyl or other agents to support kind of like the sedation or avoidance of these reactive PVR. And then sometimes we overshoot, and then it becomes difficult to know what's happening on the SVR component. But you see your diastolic blood pressure falling. This is where I start thinking, well, maybe I'll support a bit my SVR in that context, but to try to reach a point where my SVR reaching extreme levels just to reverse the shunt, I agree with you that then you get into kind of tissue ischemia and, microcirculation issues, and, lactate will rise and perfusion will get worse. So people, all these drugs are toxic in a way, and we have to be extremely careful in our babies in the way we titrate them. And of course, if they're not improving the patient, then you must kind of go back to the drawing board and reassess and then get the thought process of colleagues. Like these patients are quite unstable, and, there shouldn't be any ego about saying like, this was not the right thing for the baby. We need to reassess because it's not going well. So that would be my thoughts on that particular question. But I think like trying to drive blood pressure to a very high level using SVR increases approach just to try to reverse the shunt. I could see how this approach could lead to a lot of potential end organ injury. So I would be very, very worried and careful about kind of doing that. But yeah, these are my thoughts. I don't know if anyone else wants to comment on this.
I think this is such an interesting topic, and Irina, you're opening a can of worms because it's one of my personal pet peeves too. Because I think what I worry about is whether it was the chicken or the egg. Like, I don't know if there was already some kind of dysfunction and now it just got worse because you wanted to target a higher pressures, or you targeted a higher pressure and the LV just failed because of that, or the RV just failed because of that. So it becomes a chicken or the egg situation. And most often that targeted higher blood pressure happens typically before an echo is obtained. And so my question always is, well, do you even know if the duct is present? That's my big question. Like, you're targeting something to increase pulmonary blood flow without knowing if it's even present. It might be really tiny and not really effective in doing its job. And you don't know what the baseline function looks like. So I do agree that that's one of the things that I think is slowly evolving into more accepting lower pressures, even if, everything in general looks okay, whether it means capillary refills, acidosis, all of that, all of the other aspects look okay. Accepting even a normal number or even a low normal number is slowly evolving to be a practice. But yes, there's still existing, targeting mean arterial pressures of about 60 sometimes to help with perfusion. And yes, I question that at bedside because I get confused when the echo happens and you're like, there is dysfunction, but where did that dysfunction come from? So it's a very interesting discussion, that part.
Yeah, see, time is flying, and we have only a few minutes left. Maybe we'll do one last question if you agree, or everyone must go. Yeah, you agree? Okay, there's many questions, so I'll try to wrap them up under the umbrella of pharmacology because it seems to be kind of like the driving phenotype of these questions. So there are many questions about how to use PGE. Are you waiting for RV dysfunction or not? Are you waiting to the PDA to close or restrict? And if you see a PDA that is, for example, bidirectional and you're worried about one of these flow-driven phenotype, do you try to maintain the PDA open? So that's my first pharmacology question for the group. And then the second pharmacology question that I will want to address here is kind of what do you do in your setting about the sedation or the analgesia for some of these patients, knowing that it could have cardiovascular, impacts. Two questions in one.
These are great questions, and I think this would give you ideas on the talk because each question can be its own talk. It would, I feel like the role of like PDA patency in the setting of ventricular dysfunction is another topic that we can like talk about it for more than an hour. And then the flow-driven vein of Galen malformation is another hour talk. And then like the whole sedation or like pharmacological intervention in like cardiovascular instability, I think this warrant another talk altogether. So these are like wonderful questions.
I know. I think on their own, as you outlined, because they're so complex, it's good that people are aware that they come with a price and we have to be careful when you use them,
Yes.
Irina and Rupa, any thoughts on that?
I mean, I love PGE, so I'm going to talk a little bit about it.
You already said you love PGE.
I love PGE too.
I know you saw a smile in my face when you said that topic. So the way I think about the duct, and I'm going to try to keep it as brief as possible, is I think about PH babies having either a ductal balanced circulation, a ductal restrictive circulation, and sort of a very left to right dominant like circulation. So that's the way I think about them. And if they are like sort of ductal balanced, what I mean by ductal balanced, it's present, it's doing a decent job offloading that right ventricle. And those babies, their duct is open, it's doing its job. So I don't know if adding PGE on top of that is helpful. Now, the second physiology, which is the ductal restrictive physiology, is where I'm a little concerned and I might start them. And I think the ductal restrictive physiology, the way I think about it is, it's a small duct. It's really not doing a very good job. And the RV is looking sad and failing and really not happy at all. And so in that situation, I'm just like, well, you have this conduit. I guess we should open this up in that situation. So that's the part where I'm like, okay, ductal restrictive, you should start PGE. So RV dysfunction plus a small duct, I think about PGE. And then you have this like, this other circulation, which basically is, like our preterm PDA circulation where, the PDA is wide open and it's just full like left to right. And it might actually complicate your pulmonary compliance in that situation. Most often that does not happen in the acute setting, but if that duct is open for too long, it can complicate these situations. And we've seen that in our clinical practice as well. But to answer the specific question, it's that ductal restrictive physiology that I think about for PGE initiation.
And I agree with Rupa. I think the way I think about the role of PDA in ventricular dysfunction is, do you need that PDA to support pulmonary blood flow, or do you need that PDA to support systemic blood flow? If the answer is neither one, then the PDA might not be that helpful. But if you're trying to support blood flow either to pulmonary or systemic circulation, then in that case, the PDA patency may be helpful in that case. So I think if you have predominantly right ventricular dysfunction or predominantly left ventricular dysfunction where you need either pulmonary or systemic blood flow that is being supported through ductal shunt, in that case, using the ductal patency to help you with those flow will be helpful. I think it becomes more muddy when there is like equally bad ventricles. If you have biventricular dysfunction, then it's become very tricky.
Mm-hmm. Yeah, I agree with both of you. And I think I love PG as well too. So I think we're all in the same theme here. And I think even if you see, maybe you don't see necessarily dysfunction yet for the RV, but if you have a low RV output or like worsening systemic perfusion, if you have rising lactates, kind of end organ dysfunction, despite you've optimized, ventilation, kind of systemic support, all those good things. I think about it as well. And, obviously in combination, I like PG in combination with other vasoactives like vasopressin and milrinone potentially. So because of the dilation.
Okay, super. I think, this was really...
Question, I think. The second question, did we touch on?
Oh, yeah, the second question, a bit about the sedation, and we'll close off. Because we could talk, I see there's question on vasopressin versus norepi. There's questions about INO. These are all excellent questions. And thanks for everyone who's on the line for contributing to your thoughts. Like, I think you're outlining also so many areas of research. And so if people on the line are willing to do more research on these topics, these are great questions to kind of go back and explore and provide the community with a clear answer. So Irina, go for it for sedation approach.
I like sedation, and specifically Precedex in babies with acute pulmonary hypertension because of what Rupa mentioned. The kind of the heart rate control that it gives you, and of course. Myocardial dement and all that, all the good things that come with it. So that's usually my favorite, that's the one that I go to, I would say most often if I, for rate control and sedation, along with other sedatives.
Okay. Anyone else last words on sedation or no? I would say I do enjoy dexmedetomidine as well in some of the patients. I'm always careful if their heart rate is already very low. So sometimes if they're, with HIE and already on cooling and their heart rate is already in the 70s, then I start becoming a bit nervous. But that being said, all these agents, I don't think anyone has RCTs or great evidence. And one of the questions in the chat was about, what's the underlying evidence is for all these approaches. Well, I invite the community to create these evidence to support the research, because this is how we continue to make the best decisions for our patients. And of course, every baby you will care of will have their story, will have their particularities, and will respond potentially differently to both the medication, the dose, and the combination. So always being careful and thoughtful about how these are introduced in the care.
Just one last thought as far as, how to, in general, when you have to deal with like thinking about side effects and what medications and whatnot, I mean, it's super important to really like sit at bedside and kind of watch what they do, right? Titrate and down, for that reason, take away things. If your INO is not working, I think it was a question about that, pretty quick, right? Pretty quick, it's a quick, on and off drug. And if it's not working, it's not helping you, or if it's worsening things, then take it away. Same thing with the vasoactives, and recognize if I made a mistake and didn't interpret it correctly, right? I started a medication and then I see, well, that's not working that good. And I do it all the time, and and I go off of it or change it, right? It's very, very important to reassess and not fall into a pattern of like choosing one,
like silos,
yes, and going on forever with that
tunnel vision. Yeah,
tunnel. That's what I was
searching for. Well, on this note of wisdom, Pearl, Irina, Rupa, thank you so much for joining. Pearl, thank you for your brilliant presentation. Irina, Rupa, thank you for coming to share your experience and expertise with us. Really, this was a wonderful session, and the recording will be available on the YouTube channel.